terminal chop. I am Dr. Nishanth from MNI Hospital, Chennai. So this session is going to be a bit interesting. It's not going to be concentrated only on cataract. So we all know that a cataract with a combination is with all the other specialties. That is, we have talks on cataract with glaucoma, cataract with uvea, cataract with retina. So it is going to be interesting. So let's start. I'd like to call upon Dr. Shruti and Dr. Madan to join me here, please. So apart from the normal way of introducing, we have actually planned a different way. So I'd like to call upon Dr. Ashwathi. She's got a great interest in art and music to actually her main profession. And yes, apart from that, she's also a cataract, cornea, and a refractive surgeon from Sunrise Eye Hospital, Kerala. She's going to talk about how important is the ocular surface on a great visual comfort. Over to you.
Thank you, sir, and thank you, AIOS, for giving me this opportunity. When a very experienced cataract surgeon perform a phacoemulsification and give the patient the 6/6 vision, we feel ourselves like an angel, but we may see the satisfaction in patient's face sometimes. The so-called visual comfort may be lacking for the patient. So coming to my topic, bad ocular surface to great visual comfort. Myself, Dr. Ashwathi. So do not see the eye, see the patient as a whole. Take the history from the patient regarding the joint pain, thyroid, dry mouth, which points to rheumatoid arthritis, thyroid disease, and Sjogren syndrome. Also use of the long-term use of the ocular medicines, which damage the ocular surface, past history of trauma, ocular surgeries or infection. Do not see the phacoable eye as such, see the ocular surface like the lid, tear film, cornea, conjunctiva, and limbal stem. The ASCRS have given the preoperative ocular and surface disease algorithm. We should see the clinical examination, the LLLP. What is this LLLP? It is look, left, pull, and push. We have to see the blink, see the lid slashes and interpalpable surface, lift to see the upper lid superior surface, and pull to assess the lid laxity, and push to see the meibomian gland expression. So we can see the blepharitis here, which we miss most of the times, and treat them with the warm compression or antibiotics with the lid hygiene. Then opacity in the cornea. Pterygium, it is better to operate the pterygium and wait to see the IOL calculations. Lid marginal keratinization, better to remove this lid marginal keratinization and do the mucous membrane grafting. Conjunctival chalasis, early stages we can treat with the topical drops, and later we have to excise it. These are the various stages of the Steven-Johnson syndrome. Then pharyngeal, better reconstruct the fornix and give the amniotic membrane grafting. And lift the eyelid to see if there is any superior limbic keratitis or this filamentary keratitis. Remove this and treat with the topical drops. Lid viper epitheliopathy, or better correct the ectropion and push to see any meibomian gland expression. That is better. Treat before the and make the ocular surface healthy. And stain the eye, which we miss most of the things while staining. We'll know the severity of the dry eyes or any other pathologies. And the most important thing is the tear film assessment. If it is less than 0.1 mm, it is called the low, and high if it is greater than 0.2 mm, which indicates the reflex tearing or the deficiency of the nasolacrimal duct. Schirmer test, non-invasive T-butt, osmolarity test, and MM9 test. So why it is important to recognize the subclinical OST before the surgery? The surgery itself is a trauma which releases many inflammatory cytokines and it damages the ocular surface. And why is the tear film important? Between each blink of the healthy tear film, there will be 0.1 diopter difference. So if it is unhealthy, there is more than 1 diopter difference between the blinks, and there will be difference in the calculation. So the challenges we are facing are pre-op biometry for the IOL power calculation, intra-op visibility, increased risk of complications, compromised visual outcome, patient dissatisfaction, post-operative infection and melt. How to optimize the cataract surgery? The most important is diagnose preoperatively and counsel the patient. Address the condition to the patient and tell them that post-operatively we have to deal with this, and stabilize the ocular surface medically or surgically and manage the underlying immune etiology. If there is rheumatic arthritis, just refer to the rheumatologist. So our goals are to reduce the inflammation, resolve the infection, improve epithelial pathology, stabilize the tear film, ease the symptoms before the ophthalmic surgery, and surgery should be delayed until the ocular surface is optimized. The Tear Film and Ocular Surface Society Dry Eye Workshop has given the tiered approach for the treatment. Initially, we can try with the lubricants and non-medical modifications, lifestyle modifications like diet and lifestyle modifications. And then the topical and systemic medications can be given with non-permanent punctal, temporary punctal occlusion, expression of the meibomian gland, also the topical immunomodulators and antibiotics. Later we can give the autologous serum, eye drops and therapeutic contact lens, and higher grade we can do the mucous membrane grafts, permanent punctal occlusion and other surgical approaches. The topical drops, the ocular lubricants should be preservative free. We can give the antihistamine, antibiotics like doxycycline, azithromycin, anti-inflammatory to relieve the inflammation or any allergic pathologies. Then immunomodulator, cyclosporin A, Sequa, which is 0.09% cyclosporin, or Restasis, which is a cyclosporin emulsion 0.05%, Lifitegrast 5% solution. Systemic medications like the macrolides, omega-3 fatty acids or tetracyclines. Then procedural therapy, the meibomian gland expression, then punctal occlusion, or this is the intermittent light pulse therapy, this is LipiFlow. And ocular surface reconstruction, PROS, that is prosthetic replacement of the ocular surface to make the ocular surface healthy before the cataract surgery. The IOL selection is very important. Do not choose for the premium IOLs or toric IOLs. They can cause higher order aberrations and reduce contrast sensitivity. So this Procera and Ambiodisc, both are the amniotic membrane graft. That is, Procera is the cryopreserved amniotic membrane graft, and Ambiodisc is the dehydrated amniotic. This can hasten the ocular surface, make the ocular surface healthy before the cataract surgery. So the take-home messages are, the history and clinical examination is very important before the surgery. Counsel the patient, and surgery should be delayed until the ocular surface is optimized. We should not choose the premium IOLs or the toric IOLs. There are challenges in the IOL power calculation, and you can counsel the patient prior. Post-op, we have to use the frequent medications and for the dry eye treatment, and recognize the subclinical OST since the surgical trauma can exacerbate them. Thank you.
Thank you, Dr. Ashwati. So, as she has explained about all the preoperative things, I feel that yes, before they step into the OT, as long as they know that they have an ocular surface disorder, it is much easier to treat, one. And two, I'll say that make sure that you have a small torchlight also in your OP, because it's not only the slit lamp, there are so many findings we would find out with a torchlight evaluation too. And one of the commonest thing is also a conjunctival chalasis, which is being missed most of the times preoperatively. So they come back after a week with 6/6 with being uncooperative, and sometimes just a small knit or just a small cauterization of the conjunctiva also gives them a good satisfaction. So thanks, Dr. Ashwati, for letting us know the importance. Next, we have Dr. Advait. So he plays football, cricketer, father of a son, born in Hyderabad, but brought up in Chennai, Nama Chennai. He's a cornea, cataract, and refractive surgeon from Hyderabad and the founder of Envision Clinic. So he's going to talk to us about the cataract post-refractive surgery. I think if not this generation, the next generation is definitely going to have a lot of people with post-refractive surgery who's going to come. And we have the expert, Dr. Advait, to help us to deal with those patients. Go ahead, Advait.
Thank you, Dr. Nishanth, and thank you, AIOS, and we have a wonderful team here today. So the topic I'm going to be talking about is how to achieve emetropia in cataract patients who undergone refractive surgery. I have no financial interest. Now, refractive surgery, as we all know, that 3 decades ago it used to be radial keratotomy. Now we have the PRK, LASIK, the lenticule procedures like SMILE, SILK, CLEAR, and then we have the phakic IOLs like the implantable Collamer lenses. So why is there so much of confusion, and why is it so difficult to actually operate on such patients? Now, why is there a surgeon dilemma for cataract surgery in post-refractive surgery patients? So the topics I'm going to be covering today is the IOL power accuracy, the selection of the IOL calculation formula, the type of the intraocular lens selection, the precautions that need to be taken during cataract surgery for both the RK surgery and the LASIK surgery, counseling on patients preoperatively, and counseling on patients on any refractive surprises postoperatively. So the corneal parameters that need to be considered are the Q value, or the asphericity of the cornea, the refractive index of the cornea, the central K, anterior and the posterior corneal curvatures, and the spherical aberrations. So this is what a normal cornea looks like. It is prolate in shape, which is basically steep in the center, and it is flat in the peripheral, and then we have a central hill and the annular C. Now, so the corneal, there are some corneal changes that take place after refractive surgery. Picture A is showing your normal cornea. Picture B, if you can see, after a myopic correction, there's a central flattening that you can see in picture B. And in a hyperopic patient, basically the central steepening and a peripheral flattening. And picture D is basically showing you a patient with post-refractive surgery corneal ectasia, which is having an irregular astigmatism because of that. So this is again a patient with post-RK surgery. As you can see in the picture on the left-hand side, you can see the RK incisions. And topography can show you. Topography can basically show you over here on the corneal thickness. You can see a flat peripheral and flat center, and peripheral you can see the irregular astigmatism. In case of patients undergoing, thank you. So in cases of, it's okay. That's all right. So in cases patients undergoing refractive surgery after a myopic patient, you can see in the picture on the left-hand side, a myopic patient, there is central flattening and peripheral steepening, which is again the opposite in a patient with a hyperopic patient, where there is central steepening and the peripheral flattening. So now, in naive corneas, basically the traditional formulas such as the Holiday 1 and the SRKT do excellent job in predicting the post-surgical emetropia with refractive errors of within 0.5 diopters of emetropia. However, in post-refractive eyes, these formulas are known to be inaccurate, as both the measurements of the corneal curvature and the regression formulas have sources which contribute to the error in patients having history of refractive surgery. So we're going to be addressing those errors. One of that is the corneal power. Now, basically, after a myopic correction or a hyperopic correction, basically what is happening is after a myopic correction, the central cornea is becoming flatter. Thank you. And after hyperopic correction, the cornea is becoming steeper in the central. Now, this basically leads to an overestimation of the corneal power, leading to a hyperopic outcome after a myopic ablation and a myopic outcome after a hyperopic ablation. Now, the corneal ablation changes the anterior and the posterior corneal curvature. Thus, the assumption of the refractive index of 1.3375 is no longer accurate. Now, effective lens position estimation error. Most of the theoretically based IOL formulas like the SRKT, the Holiday 1, 2, Hoffer Q, and the Barrett universal formula, these basically use both the measured axial length and the keratometry to estimate the effective lens position. Now, there is an inaccuracy in the keratometry reading. Why is that? Because the manual and the automated keratometry, the reflected Myers, are within 3 mm of the optical zone. Now, the corneal power given is basically derived with the assumptions of the corneal index and the relationship of the anterior and the posterior cornea. To measure the true corneal power, both the anterior and the posterior surface must be considered. So let's look into the IOL formulas that are required for patients with RK. Now, Dr. Nishanth was talking about maybe after a few decades, we'll start seeing patients post-refractive surgery. So we are seeing a lot of patients who undergone RK surgery 20, 30 years ago who are actually coming down with cataract. So basically what is happening here is the IOL power calculation requires the axial length, keratometry, and the AC depth parameters. So formulas like SRKT, Hoffer-Q, Holiday 1 are dependent for the ACD measurements on the keratometer values for the estimated lens position. As you can see the picture in the B over here, these are the changes that take place post RK surgery. So basically after the refractive surgery, the central cornea power changes. There is progressive flattening of the central cornea. There is irregular astigmatism, which basically affects the ACD measurement and the estimated lens position. So the IOL formula that need to be considered in RK, we have the true K and the standard Haigis methods, which basically perform very good with only minus 0.5 diopters offsets. The advantage of the true K is that the magnitude of the RK correction is known. So true K basically uses the post-RK refraction and the current biometry to estimate the preoperative corneal curvature and the effective lens placement. So basically it predicts changes in the refraction using the axial length, the AC depth and the current keratometry to estimate the preoperative keratometry. In post LASIK, the IOL formulas that can be taken are the TK, that is the total keratometry. We have the Barrett TK2 formula. We have the Barrett TK toric. We have the Holiday EKR, that is EKR is equivalent keratometry reading that are taken from the pentacam, and the combination of all the formulas. So the equipments basically are required for the measurements. We have the OpScan and pentacam. Now the topography basically gives you more number of measurements of the cornea. It also gives you the measurement of the anterior and the posterior curvature of the cornea. We have the OCT, the abrometers and eye trace. And now we have the advanced biometers like the IOL Master 700 and the Lenstar LS900. The advantages of these biometers is that it has an inbuilt software which basically calculates the power for post-refractive patients, and the chance of post-operative refractive surprises is very rare. And of course, those who do not have access to the advanced biometers, there's always a zero cost online calculator available, that is the ACRS online calculator. Now all you need to do is you just have to enter the values. In case you have the preoperative pre-refractive surgery values, these can be entered. In case you do not have any pre-refractive surgery values, which is in most of the patients, you can just enter the values that are available with you, and with this the ACRS online calculator will give you quite a good precise number. In case you're having access to both the ACRS online calculator and the biometer, you can always try both, and in initial cases you can see which works best for you, and you can continue in your practice with that. So then we have the intraoperative precautions that need to be taken for RK surgery. So because of the corneal incision, it is better to take a scleral tunnel incision, and if you are taking corneal incision, you would please take it between the incisions. If it is an 8-cut incision, you can take a 2.8 millimeter keratome. If it is a 12-cut incision, you can take a 2.2 millimeter keratome. So throughout the procedure, make sure the portal height is low, the AC should be maintained, and do not overfill the anterior chamber with viscoelastic, and always keep suture ready, and in case the incisions open up, please be ready to suture the incisions. Intraoperative precautions in patients with LASIK or PRK. In LASIK patients, it is very important to determine the LASIK position, the flap and hinge position, and do not disturb the flap position during the surgery, so that you do not want any epithelial ingrowth. In case of PRK, in case of haze, it's always better to stain the capsule with trypan blue for the excess. So the intraocular lens selection, post-RK or myopic LASIK patients exhibit better outcomes with aspheric IOLs that introduce a negative spherical aberration, like we have the IQ and the Technis lens. In hyperopic LASIK patients, they tend to do well with spherical aberration neutral IOLs, like the single-piece lenses. Now it is very important to measure the spherical aberration, and it is crucial in the decision-making process. So you can utilize tools like pentacam, eye trace and abrometers for a comprehensive assessment. Now there are some contraindications for multifocal IOLs or toric IOLs, where in case of irregular astigmatism, which is shown on the topography, it is generally advisable to avoid multifocal and toric IOLs. Patient counseling, this I feel is the most important part. Now definitely patients who undergo refractive surgery, they expect a bladeless procedure, they expect a wow factor, they want a 6x6 vision day one. Now it is very important to counsel such patients that it is not the same outcome that you expect post-cataract surgery. Now also patients who undergo refractive surgery, they might want a glass-free life because they've been leading a glass-free life, so they might ask you for a presbyopic correcting IOLs. So it is important that you educate the patients and tell them about the chance of glare, especially in those who have been induced to high-order aberrations post-refractive surgery. So post-operative surprises, in case of, again, counseling is very important. In case of any small refractive errors, it can be managed with contact lenses or glasses. Alternatively, we can do a PRK or LASIK for small errors to reach the desired refraction. And for larger amount of IOLs, you can always do a piggyback IOL or an IOL exchange. And again, it is very important to counsel such patients because we are reoperating on patients with high myopia, so there's always a risk of glaucoma, inflammation or any retinal tears. So to conclude, implement various latest regression techniques and explore different methodologies for calculating IOL power. Use topographers or biometers for better keratometry, and of course ACRS online calculator is there, which is zero cost, And in case you have access, in case you have biometries like IOL Master 700, it gives quite an accurate calculation. And please do inform your patients about the possibility of unexpected refractory outcomes, and do manage them, and manage patient expectations regarding any post-surgery vision. Thank you.
Thank you, Dr. Advait. That was a very comprehensive overview of post-refractive cataract surgery, and it's a very technically challenging area of expertise, because we need to, these are patients who are already in need of perfect vision. They've already sought the first surgery for freedom from glasses, and then we have to come for the second thing. We have to again satisfy their goal. So here I would add that probably when we do the IOL power calculation, we can depend on the optical biometer, the immersion, and the ACRS calculator, and use all of it to put together and get us the right power, and then make sure that it is consistent across all the three platforms. Another thing is we can also try and explore areas of enhanced monovision, like the true EDOF lenses in these kind of patients. They tend to do much better than the multifocal patients. So that would be my comment.
Yeah, so just to continue, what I usually follow is 3 machines, 3 readings. So all the 3 machines, that is the optical biometer, the immersion method, and the ESCRS, we have to calculate 3 readings, take an average out of all the 3. And actually I had a very nice point told by Dr. Samresh, who said that I show the patient, because these are post-refractive, there might be some refractive surprises. So you show the patient that we have done the best, this is the power we are going to implant. So you can see that we have showed them, write it down, and then we can tell them that if any surprises come, they might need. So I think that was a very nice point which I heard from him, which I wanted to share, that show the patient that we have done the best, and this is what we are going to implant even before we are going to implant. Just wanted to share that. Thank you, Dr. Advait. Next, we have Dr. Nagalakshmi Ganesh, and she loves sports, mainly athletics, badminton, and she's into fitness. She's a glaucoma consultant at MNI Hospital, Besanagar, and also a consultant in Dr. Kamakshi Memorial Hospital. So she's going to talk to us about the IOP spike, how to control before, during, and after phacoemulsification. Over to you, Dr. Nagalakshmi.
Thank you, Dr. Nishanth. Thank you, AOS, for the opportunity. So we all love to see a pre-op pre-op case like this, and a post-op picture like this. However, there are days when we encounter scenarios like these as well, and very often than not, control of intraocular pressure determines the outcome in most of these cases. So my top 5 cents for controlling IOP spike before phacoemulsification, first would be to anticipate red flags. Keep your antennas on when you see glaucomatous eyes, high intraocular pressures, shallow ACs, lens-induced glaucoma, pseudo-exfoliation, short eyes, traumatic cataracts, and when there has been a complicated surgery in the other eye. Always plan to keep the IOP at an optimal level before you proceed with the surgery. When topical anti-glaucoma agents are not sufficient, go and give the patient oral acetazolamide. Usually that takes about 1 to 2 hours to start its effect. Intravenous mannitol takes about 5 to 10 minutes, and hence can be used intraoperatively as well. And oral glycerol also has its role in non-diabetics. We also very often come across shallow anterior chambers, and there are various studies which have shown the advantages of early phacoemulsification when compared to laser peripheral iridotomy in these shallow ACs. However, make sure that you always check the post-dilated intraocular pressure in the OPD preoperatively itself, and give instructions not to dilate the patient prior, and prefer to dilate the patients in the theatre under oral acetazolamide or mannitol cover. Also keep a check on the axial length, because very often they have shorter axial lengths, and choose your IOL calculation accordingly. Also make note of the endothelial count, and plan OVDs accordingly, because shallow AC increases the risk of endothelial loss as well. And in case you're not dealing with a primary angle closure, do a detailed angle study. Use machines like UBM to know the cause for secondary angle closure, because that also sometimes gives cues regarding the zonular status. And counseling and VR backup should be planned accordingly. So as I told you, there are multiple studies which have shown the superiority of early phacoemulsification compared to laser peripheral iridotomies in angle closure, even in acute angle closures and in angle closure glaucomas. However, this does not always hold good, especially when the intraocular pressure is more than 55 millimeters of mercury. The EAGLE group extended the benefits of the phacoemulsification in the angle closure eyes, recommending clear lens extraction in angle closures and angle closure glaucoma. However, we'll have to keep in mind that this cater to a specific set of study population and cannot always be extended to the rest of the population. Though the complications were much lesser in the early phacoemulsification group, these were sight-threatening and had long-term visual implications. So choose your patients for phacoemulsification accordingly. The fourth step would be the decision-making to do combined surgery. We all know that advanced glaucomas, patients who are on 3 or more anti-glaucoma medications, they might require a combined trabeculectomy along with phacoemulsification. In cases where the disc view is precluded, like in lens-induced glaucomas, look for the presence of RAPD, which again gives a cue regarding the disc status. In the dawn of mix, mild and moderate glaucomas with cataract, you can combine it with mix as well. Angle closures, goniosynochial can also be combined with phacoemulsification. The fifth important point would be to plan the local anesthesia, because very often we foresee a longer surgery, and hence we might want to give a needle block. However, make sure that you use minimal volume, and if required, supplement by other methods. You can use ocular decompressive devices to keep the IOP less preoperatively, and always check finger tension before you make the first incision. However, if you do encounter a retrobulbar hemorrhage, put off the surgery, give IOP reducing agents, keep a close watch on the vision and the fundus, and the earliest sign of optic nerve ischemia, don't hesitate to perform a lateral canthotomy. Now going on to measures to control intraoperative IOP spikes. We know the long-term implications of high intraocular pressure intraoperatively. When dealing with shallow anterior chamber, always make sure that the preoperative IOP is kept as optimal as possible to prevent sudden hypotony, decompress slowly, and when very often it is also combined with smaller pupils, so use adequate OVDs to keep the anterior chamber pressurized. Don't hesitate to use trypan blue, and use do a phacoemulsification in the bag or at the level of the iris plane to avoid endothelial loss, and avoid techniques like flip and chip and cartwheeling in the anterior chamber. Also make sure that we keep the anterior chamber formed before placing the IOL to avoid globe distortion. So again, we also very often come across situations like this where iris prolapse can complicate the surgery. So here, while removing the last piece, the patient was complaining of pain and AC shallow. We can see that the iris starts coming out through either of the side ports. I try pushing the iris inside, but it just doesn't go in. Patient is complaining of pain, and there is high positive pressure. So step one would be to address all the positive pressure factors, loosen the speculum, use intravenous mannitol, lower the phacoparameters, and address the other positive Valsalva maneuvers, and pray for your best. And here, thankfully, I get away with all these measures, and the iris does fall back, and I get away without any complications. However, sometimes we might want to take help from the VR team and decompress from behind, do a minimal core vitrectomy before proceeding with the phacoemulsification. So the most dreaded complication happens to be the expulsive hemorrhage, why we all fear the IOP spike. So this very often happens because of a sudden hypotony, which is because of, which causes the choroidal vessels to leak, stretching the posterior ciliary vessels, and thus causing the expulsive hemorrhage. So the risk factors here would be sudden hypotony, Valsalva maneuvers, old age, hypertension, anticoagulants, myopic eyes, prior vitrectomized eyes, and aphakic eyes. So there is an interesting article by the British Journal which showed that most of the expulsives happen following nucleus removal when the globe is distorted. So hence it is important that we always keep the anterior chamber formed at any stage of phacoemulsification. So in case expulsive does happen, then we might want to promptly close the wound, excise prolapsed iris, reduce the intraocular pressure, keep a check on the blood pressure as well, and if we have the expertise, do a choroidal drainage. However, if you want to manage it post-operatively, wait for at least 1 to 2 weeks, follow them with serial ultrasounds, and then plan the choroidal drainage. Now the second situation where the IOP complicates surgery are in lens-induced glaucomas. We might still want to consider phaco in these cases because of the smaller incision and the sparing of the conjunctiva, which offers greater room for trabeculectomy at a later setting if required. And being a closed chamber procedure, the risks of expulsive also remains less. However, the most challenging aspect of managing such cases with phaco would be the performance of a CCC. So we can employ techniques like the fine needle aspiration technique, where we use a 30 gauge needle, bevel down and decompress the lens, aspirate the lens material. We can see the convexity has come down already, the intralenticular pressure is down, and the phaco can be completed with ease after a successful CCC. So also the newer and better machines are available with sensors in the handpiece, active fluidics, which helps in maintaining the pressures, intraocular pressure during intraop. So talking about managing IOP after cataract surgery, high IOP remains the most common postoperative complication. As high as 45% have high IOP of 28 millimeters and more for the first 24 hours. And this is an interesting article which shows that preoperative Diamox helps in bringing down this postoperative IOP spike, which usually happens 3 to 5 hours following a cataract surgery, which even a postoperative oral azithromycin does not address. So as we evaluate IOP spikes post-op, look at the anterior chamber. If the anterior chamber is formed, very often it is a retained viscoelastic which causes the trouble, which can be confirmed by the absence of aqueous currents and inflammation because of surgical trauma, and air-filled eye, retained lenticular debris, pigment dispersion, hyphema and infection remains the other causes. Some of the most important causes for late intraocular pressure spike with the deep AC would be steroid response, and sometimes because the foldable single piece IOL in the sulcus can also incite inflammation and intraocular pressure rise. The risk factors for steroid-induced glaucomas are open angle glaucomas, myopic eyes, traumatic angle recession, pigment dispersion. Here we would like to discontinue the steroids or substitute with a non-steroidal agent or with a lesser potent steroid, because the potency has a direct effect on the IOP as well, and that failing might require surgery or laser. When we are looking at shallow anterior chamber and high IOP, very often it is because of the air which causes a pupillary block. We would want to dilate such patients, keep them in supine position, bring the air out, or do a peripheral iridectomy in such cases. And the other important cause remains the malignant glaucoma. The risk factors would be shallow anterior chambers, hypermetropic eyes, angle closure glaucoma, and nanophthalmic eyes. The mechanism is a ciliolenticular block which causes posterior diversion of the aqueous and forward movement of the lens iris diaphragm. So here the management would be medical initially with atropinization. That failing, in pseudophakic eyes we can try a YAG iridotomy and hyalodotomy through the PI or through the capsule. That failing, we might want to intervene surgically by irido-zonlo hyalodotomy. So these are two of the cases that we had managed. The first one responded to hyalodotomy, and the second one required irido-zonlo hyalodotomy, where we make the anterior and the posterior chamber into one, reducing the pressure difference, and this was also combined with a synecholysis. So the take-home message is always do a meticulous planning preoperatively, prevent intraocular pressure and chamber fluctuation intraoperatively, and probe and manage the cause postoperatively. Thank you for the patient hearing.
Thank you, Dr. Nagalakshmi. Just one question in terms of the mannitol which you give intraop. So we actually give for people who we block. Do we give mannitol, then block the patient, then operate, or we block the patient, then give mannitol, then operate?
Depends upon the preoperative IOP that we are dealing with. If the pressures have not been under control with the maximum topical medication, and we can always check preoperatively, and NCT can always be done. If the pressures are not under control, it makes sense to bring it down as much as possible. So we might want to load the patient with as much as medication as possible to keep it optimal. However, if it is say a shallow anterior chamber and initially to begin with the pressures are not high, we might keep the mannitol as a reserve, because as I was mentioning, the action starts as early as 5 to 10 minutes. So in such cases, maybe we can keep it handy as a backup and then take a call on that.
Thank you.
Thank you, Dr. Nagalakshmi. Now I'd like to call Dr. Nishanth. She'll be speaking to us about traumatic pediatric cataract do's and don'ts. She is a poet who loves art, music, and good literature. She is a pediatric ophthalmologist at MNI Hospital, Chennai. Dr. Shruti.
Yeah, thank you so much. So today I'm going to be discussing about one aspect, which is the pediatric traumatic cataracts and how we deal with it. So traumatic cataracts in pediatric is like a double whammy, because you're dealing with a pediatric eye and as well as a trauma. Both are in ready to incite trouble for us. Can we play the video, please? Okay, so the concerns that we are looking at is the type of cataract. More often than not, these are total cataracts because of the injury, and some of them are blunt injury, some of them are penetrating. The status of the posterior capsule more often than not cannot be assessed in these cases, so we need to do it intraoperatively. The timing of the surgery is again very important. I wouldn't recommend to go in and put in an IOL in the primary setting. We always do the repair and then we go plan for a secondary setting IOL after 6 to 8 weeks. So primary setting only if ALC is breached, then we do a cataract clearance, but we still don't place the IOL in the first setting. The second stage, why we plan the IOL, is because of regular cornea, better IOL power calculation, there's lesser inflammation and better IOL centration. Now this was a 13-year-old kid who came in with injury with these blades that they play with, and you can see this cut straight through. This patient was first managed primary repair with a corneal tear suturing, and then followed by which the sutures were removed, and then the keratometry was found to be regular, and then only then the IOL power calculation was done. So this was almost 8 weeks after the initial injury was done and the sutures were removed. After suture removal, about a week or two is when we planned for the IOL power calculation and then go in for the placement of the IOL. So here you can see this nice big iris defect in the inferior aspect. And here I'm trying to see there's a PAS, there's a anterior attachment of the iris there, but I'm trying not to relieve it at the moment. So minimal removal of this kind of attachment of the iris is done. Handling has to be very gentle and very minimal. Again, you see the initial nick being done, and this is a Grishaber's intraocular rexus forceps. The holding is quite good with this and can be done through the side port. And here you can see because it's a traumatic cataract, where the lens and the capsule may also be unpredictable to start off. So use adequate high whisk. Under high whisk, you can use this nice movement to centripetal movement to bring inwards, so that these pediatric cataracts tend to have extensions. So again, keep refilling viscoelastic wherever we feel that we are not getting the traction enough. And once we almost complete it, you can see the nice round rexus. The cataract removal per se is very easy, because we just need to do a irrigation the aspiration part. And this is placement of the IOL in the bag, because the bag was intact in this patient. Now what's important is to dial them with care, use a counter traction and then rotate them. Here I'm placing both the haptics on the side so that they don't interfere much with the lower portion, because you don't want to see a haptic in the visual axis, because there's an iris defect there. And then after placing the IOL is where we actually remove these adhesions and the extra things that we want to do. And here you can clearly see this thing. I know it's very tempting for the surgeon to kind of do an iris repair at this point, but believe me, in pediatric cataracts, less is more. So we manipulate as less as possible, and we'll be surprised at the way these children find these small areas where they can start seeing. This child actually saw 6/9. And that's a real good improvement, and they don't complain of this diplopia and other issues, because they have a very good neural plasticity. They tend to see well, and they kind of figure out where they want to see through. So no excessive iris repairs or all of that. We can save that for the postoperative secondary or tertiary procedures. Again, any traumatic cataract, please suture them, and the main wood has to be used 2 sutures, 10-0 nylon or 10-0 vicryl can be used. This patient was followed up with hourly steroids, because inflammation is expected. And the first week I follow them up every 2 days, because the first week is the most critical period where the inflammation comes back. Once you have a nice pupillary membrane formation there, then again the whole point is lost, the visual axis is gone, and amblyopia sets in. So make sure the inflammation is subsided right from day 1. Plan for amblyopia therapy within 1 week of the surgery, so that the child does not go into amblyopia, and plan for EUA as well. This was another patient, again a 13-year-old guy with a history of a cracker injury, sudden loss of vision with pain and watering. The left eye had hand movements. Again, in this patient, we had to take, this was how the picture was, almost like a total subtotal hyphema with 3 mm, and you can see this dilated pupil, and we can't see much, but there is definitely a cataract. So this child was scheduled for AC wash in the primary setting, and after which we planned for the cataract procedure. And here you can again see that this vitreous echoes, low to moderate vitreous echoes in the vitreous cavity, and the retina appears to be on. So with this stage, we started the child on topical antibiotic because this was a blunt injury. This was not a penetrating injury. Here you can plan for a IOL in the primary setting itself. So once you take care of the inflammation and the glaucoma and all of that, and look for the intraocular pressures, the plan for this patient was lens aspiration with CTR because there was a little bit of phacodonosis with intraocular lens implantation and vitrectomy. Now in traumatic cataracts, I usually don't recommend to go for a posterior capsulotomy sometimes when there is a penetrating injury, because there is an onus of having introduced something foreign into the eye. So you can plan for a YAG later on because that's a little more sterile. But in some cases where the child is really young and they wouldn't cooperate for a YAG, it's always good to go ahead and do that. Make sure you inject some good antibiotic at the end of the surgery, intracameral antibiotic. So here again we watch out for a weak bag and vitreous prolapse. So that's something in our mind. And here again you see this child, blunt injury, so there's no penetrating injury here. Make a good two good side ports, and you can see these nice posterior synechiae, the synechiae that's developed there. Again, use the trypan blue to stain it. Gives a little more strength to the anterior lens capsule, so it isn't as elastic as it is without the stain. So I always stain them because it provides some strength to the capsule. Here again we tend to use a spatula to kind of gently release these adhesions, and while we release, just make sure and look at the way the eye is, the lens is moving, because that gives you a clue whether the bag is weak or not in that aspect. Again, you will not have any clue as to how the posterior capsule is at this point, so we need to take it really carefully. So gently release these adhesions, and these adhesions can be broad based, they can be over some distance, so make sure you sweep all the way through up to the angle. So make an initial nick again, and with the nick, because this was slightly older cataract, we can use an Utratas or a Rexis, Rexis itself to kind of start initiate it and then move it. We can use an Utratas or a Grishaber's intraocular Rexis forceps. You can see me starting off with the capsulorhexis needle itself, but as you go on, I see that I'm not having the good control. So I will immediately shift to the intraocular rhexis forceps here, because this is a very critical point where extension can happen. It's important to stay away from the area of the posterior synechiae, and that's important because that's probably where the extension happens or the tears happen. So again, very critical area here. Do it really slowly, and once you get the right traction at this point, you can just turn it, and then all the motion has to be centripetal, unlike in adult cataracts. So almost at the end of the capsulorhexis here, you can see it's coming in nicely, and that completes the capsulorhexis. So once the capsulorhexis is done, then it's lens aspiration is very simple. We try to kind of release it just using irrigation, but then we need to bring in the irrigation aspiration as well. So here you can see the irrigation aspiration. So removal of the cataract is very easy in pediatric cataracts. The only thing is, as you are aspirating, just keep an eye on the PC, because we don't know the status of the PC. So just keep an eye on how the PC is at that point. And something that I've not done here, but I would recommend, is to keep the irrigation probe towards the angle and towards the side, so that you're not directly irrigating the vitreous if it is exposed. So here again, we're removing the cortex, and once that is done, we do realize that there is no PC defect at this point, so that's a safe thing. Again, here I would not endeavor to do a direct posterior rhexis in the first setting. So what we plan to do is to place a CTR to provide the adequate support, because somehow we felt that the other side did not have the support. So we can see the CTR being placed. So once the CTR is placed and the bag has adequate support, then we go in with the IOL placement. So again, in pediatric cataracts, we tend to use hydrophobic acrylic single piece IOL in the bag placement. So here I wanted to place we wanted to place a three piece IOL, so that it provides a little better support. So just gently nudging it in, and placing the haptics at the area of the deficiency provides a little better support. So that's what's being attempted here. So just gently nudging in the IOL, and the IOL is quite centered. At this point, we take a call to do the vitrectomy, because somehow the posterior capsule was not very clear. So again, a troca was placed, and we plan to do a vitrector rhexis from the posterior, from the pars plana approach. So the irrigation probe can be placed in the anterior segment itself, and just you can see a clear, nice vitrector rectus being performed in the from the posterior aspect from the pars plana approach. And once we make a nice clear opening, we are pretty sure that the visual axis is clear, and that's very important. We can make a nice big one because we know that at this point the iris is also going to be slightly dilated because of the trauma. So removal of some of the peripheral debris as well. And once that's done, again we need to suture the ports, and that's very important in traumatic cataracts, to suture the ports and make sure all the ports are wound airtight. Because they do not have very good scleral rigidity, so it's important to suture them, all pediatric cataracts who have undergone trauma. So once the trocar is removed, so this is the post-op day 1 and day 10. You can see how well the central the IOL is, and the child had a good vision of 6, 9 and N10. Thank you.
Thank you, Dr. Shruti. As a VR surgeon, I've got only one question. How often would you do an SFIOL, and do you have an age cutoff where you would say no SFIOLs below this age, or for that matter even iris closed lenses?
Well, I would think that around 8 years is when the child kind of goes into this kind of complete development, and anything beyond 8 years I would definitely recommend an SFIOL if there's no good back support. But lesser than that, there is a higher chance of displacement, or this higher chance of extrusions. So I would probably reserve it up to maybe around 8 years and above.
Iris closed lens also same?
Yes, similar. And of course there should be no systemic contraindications and collagen-based deficiencies.
Thank you,
Thank you.
Dr. Shruti. Next, I'd like to call Dr. Nishanth. He'd be speaking about not a clear cornea management techniques in phaco. So Dr. Nishanth is an ardent sports person. He's an adventure lover, adrenaline junkie, I would say. So he enjoys music as well. He's a cataract, cornea and refractive surgeon at MNI Hospital. Dr. Nishanth.
Thank you. Good evening. I know that this course is in between you and Javed Ali's concert. So just got 3 more amazing talks over here. We all, as a cataract surgeon, I'm sure that we would like to have clear corneas, but what if we are not getting so clear corneas is what I'm going to talk about. So what do you call a compromised cornea? Any cornea which is unhealthy, the local causes such as degeneration, endothelial diseases, post-refractive surgery, or previously operated eye. And what are the pre-evaluation pearls which are required? Make sure that you document all the corneal pathology either by slit lamp photography or specular microscopy. Take adequate PACI because sometimes, or even ASOCT, because they also give a lot more pathologies of the cornea as well. Counseling is very important, like Dr. Ashwati told in her talk about the risk which was involved in compromised corneas, difficulties even during the surgeries, because we are not going to have the glow as much as what we expect. And the prognosis and the outcome is also definitely much needed. So epithelial problems can cause problems like post-cataract surgery. You might have a persistent epithelial defect. While hydrating, you will actually realize that you have epithelial ballooning and you might not have a proper clear epithelium. And this all happens in mainly the epithelial basement membrane dystrophies, which might be missed in a normal slit lamp as well. People with Bell's palsy and exposure keratitis is also definite to look out for it, because they might have an adequate exposure. Post-RK and post-PK surgeries, I think Dr. Advait has covered it in his talk. Fuchs dystrophy is one of the most important indication, because we actually, the same way the earlier cases we tend to miss. So make sure that the endothelium of every cataract patient is looked at, even just with extra 3 or 5 seconds. Make sure that you look at the endothelium. Herpetic corneas, it's not only the scarring which happens after the post-herpetic conditions, it's also the loss of the corneal nerves and sensations, which could cause recurrent epithelial erosions and constant irritation to the patient post-herpetic. So make sure that they also get pre-herpetic, before the cataract surgery, I do start them on IC556 400 milligrams 3 times a day as a dose for about a week or 10 days. For Bell's palsy, you make sure that the ocular surface is treated first. There can be some tarsography which can be done as well, and taping of lid can be done in the night also. Corneal scars depends upon the depth. whether it is leukomatous, macular or full thickness, whether you want to do a combined procedure or whether you want to do the corneal procedure first. I have few surgeries which I have done the corneal procedure, the phaco first, and then there are some procedures where you can do the cornea first. The main thing about doing the phaco is if you are able to get a proper IOL power calculation, I'll say yes, you can go ahead with it. And the need of customized IOLs like toric or aspheric lenses is also based on the corneal topography. So as I've told about all the duct toxicity, make sure that the cornea is, that's one of the main complications is the cornea anesthesia, which can lead to neurotrophic keratitis or infectious keratitis or immune ulcers post cataract surgery. The other consideration is you can also start with scleral tunnel, which is actually very good. Not all clear corneal phacos are perfect, and superficial keratectomy in EBMD diseases, management of pterygium first and then the cataract if at all you have a lot of astigmatism, and avoid premium lenses. Sometimes we have patients nowadays who come saying that not a problem sir, whatever it is I understand, but still put a premium lens. But if you feel that no, this patient will not be happy, never operate for the patient's sake, because I think those days are gone, because the day one they come back saying that I never told you, you only advised this lens. So please, please, please put only multifocal or trifocal or any of those premium lenses if you are satisfied with the ocular surface. Systemic problems, yes, we have to look at them as a whole. We always, I think all the talks say that don't look at only the ocular surface. Look at the patient as a whole from the top to bottom and find out what all that they have been taking as in terms of long-term medications. Endothelial diseases, specular microscopy, very important. Cell count not less than 700 per cubic millimeter. Slit lamp photos, intraoperatively use abundant visco. The best is the soft shell technique. And even though you are a surgeon who operates within 5 minutes, be it stop and chop or direct chop, after phaco 1 or after a trench, make sure that you can put some more viscoelastic. It is just going to take 5 seconds extra, but I'm sure that's worth benefit for the patient and for you as well. Cold phaco techniques, and not always phaco is the hero. I have a case of SICS which I'll be showing you, where the best thing is after SICS the cornea is still clear. Whether you want to do it combined or alone, it depends upon the endothelial cell loss, because we all know that during phaco there is a cell loss around 6% to 12%. So even if you try to reduce the phaco energy, or you do in the back phaco, or use the phaco and the Ozel technique, you will still have endothelial cell loss is what we say finally. So counsel the patient that the chance and the need of endothelial surgeries might be required after any phaco surgery with endothelial problems. Combined procedures, yes, it can be PK with ECC IOL or phaco with IOL. I never prefer PK with IOL because it is an open sky technique. I mean, we surgeons are afraid of the complication, which I think Dr. Naga has explained, that the expulsive hemorrhage is there. So as the sooner you close the eye, the better it is. If you're planning for a surgery, I would rather do a phaco IOL or a DSEC, not an ECC with IOL. So these are few pictures thanks to Dr. Sujata Mohan for sharing, and she's done a lot of combined procedures. You are not sure that whether this patient has undergone phaco or a DSEC. So indication for two-step procedures is if they have a severe stromal dystrophy, you have to make sure that the depth of the dystrophy is important. I don't think if there is any endothelial involvement, make sure that you do a PK. Don't do only an anterior DALK and then later on come into recurrence. So post-refractive surgery was dealt in detail by Dr. Advait, who told us that in few years' time, yes, we are going to get a lot of patients who are post-refractive and who demand not cataract surgery but a refractive cataract surgery. So problems in keratoconus is they are not clear. I mean, the astigmatism is not straight, so there are irregular astigmatism, so you're not sure about the toricity. So even in these cases, you can try to stabilize the cone. So we do something called a trek, where we try to make sure that the cornea becomes symmetrical, and then we can decide on whether we want to put a toric or a monofocal lenses. The lid margin is one of the main thing to see more than the slit lamp. As I told you, it is only the torchlight which gives you a much better benefit. So these are just last video which I've showed. So this is a leukomatous opacity. So I start by doing the rhexis underneath the opacity, because once you start getting that, and then the rexus is going to be, you can see that because it was a full thickness penetration, the even anterior capsule was also damaged. All my trenching will be at the side. Do not go underneath. Just make sure that you are away from the area of the opacity. Look, my phaco probe is always to the right a bit. It never goes under the area of the scar. And if you have good microscope with good retroillumination, I always use a bimanual technique because it is something like a third arm. You can always retract the iris, you can always move the eye, and then you can visualize with the area of cortex and you can remove them. This is a case of post-viral scar which was stable for almost 6 months with no recurrence. So the whole surgery, usually I don't do it in this red glow alone because it gives a good rexus, but in terms of the nuclear management, I am comfortable with both the red glow and the normal line. Even here you can see that the area of where I am able to find a bit of clear cornea is where my phaco probe is, and don't go underneath the area of the scar. This is where I told you. So this patient had some vision. Almost be wondering why I didn't do the PK first, because the scar was little off the axis, just inferior, and the patient actually felt that he could see something above the scar. So what we did was I just released the adherent glaucoma, and it was a brown to black cataract, and you can see I didn't even try a rexus. Please don't show your heroic skills. You see what is best for a patient. I just did a can opener technique and I did a small incision cataract surgery. So outcome, post keratoplasty, plan suture removal before the cataract surgery, and do combined procedures whenever required. Thank you everyone.
Thank you, Dr. Nishanth, very comprehensive.
Cataract. It's cataract that develops secondary to other intraocular conditions, most common of which is chronic or recurrent uveitis. Others are retinal detachment, glaucoma, myopia, intraocular tumors, and other conditions such as RP. In interest of today's topic, we're going to be sticking to uveitis. So where are the road bumps when you're going to be operating a case of cataract secondary to uveitis? So first thing, band-shaped keratopathy going from anterior to posterior. You could have a band-shaped keratopathy. There could be peripheral anterior synechia, which could make your AC shallow. And then the small or non-dilating pupil along with posterior synechia. After the surgery, of course, there's a higher incidence of post-op macular edema, and always the inflammation could be reactivated. But every problem comes with its solution, and I think I'm going to divide my talk into these things. So the following subheadings: you should do a thorough pre-op evaluation, and then there should be a proper planning for your surgery. There should be very meticulous post-op care. And I think the last but not the least is, I think, take the patient in on the discussion about the possible risks, outcomes, and complications, and the possible need for a prolonged course of post-op topicals and medicines. So in terms of pre-op or prep work, the dictum is 3 months of no active inflammation before you plan a surgery. There's no bypassing that. How do we suppress the inflammation in the eye before? So we have topical steroids, systemic steroids, periocular steroids or intravitreal implants, and immunosuppressants. Also in our armamentarium is topical NSAIDs, which we should start prior to the surgery in anticipation of post-op cystoid macular edema. And in cases of band-shaped keratopathies hindering visualization, an EDTA chelation or a phototherapeutic keratectomy should be done well ahead of the planned date of surgery to get that out of the way. So pre-op immunosuppression, what do we do, topical or systemic? So if your uveitis is non-granulomatous anterior uveitis, topical steroids alone will suffice, and they should be started 3 to 7 days prior to surgery. In case of granulomatous anterior uveitis, intermediate or panuveitis, you definitely need oral steroids. So prednisolone has to be added or stepped up. If the patient is already on systemic steroids, it needs to be stepped up. So intra-op, of course, these stand for every surgery, but then you have to keep these more in mind while doing uveitic cataracts. You have to take utmost care to cause as minimum trauma to the iris as possible. Find the age of the patient, etiology of the uveitis, chronicity and course, and how well it has been managed all along. Any posterior segment pathologies, and how good the inflammation control was before surgery. These patients are left aphakic owing to intense cyclitic membrane formation and intractable inflammation. And in cases of herpetic uveitis, you've got to start oral AC with 2 grams per day or 1 to 3 grams per day of valacyclovir, which is the therapeutic dose, 1 week prior to surgery, followed by the prophylactic dose of 600 to 800 mg per day of acivir or 500 to 1000 mg per day of valacyclovir for 4 weeks post-surgery.
Back here, the fluid wins anteriorly rather than posteriorly into the vitreous. Ocular trauma is another instance where zonular integrity, capsular integrity could be compromised. You could have retained intraocular foreign bodies and coexistent open globe injuries. So this is a particular child with a lot of zonular loss, liquid cortex, and here it takes it would be better to go for vitrectomy and clean up the entire thing in a matter of seconds before going ahead with the actual vitreoretinal procedure. Now this is the common situation we get when you have vitreous hemorrhage or a retinal detachment. You would have poor red glow, you would have a thick posterior plate, a small pupil, and flax if available would really be useful in these scenarios. A small video to show what would be expected. As I said, a hard cataract, avoid too many trenching maneuvers if possible, try to crack, and even this is not going to be easy because the posterior plate is going to be hard. You might have to release, regrip, and take it slow. Make sure that the posterior plate has actually separated before going ahead. I mean, make as many quadrants as possible, and in doing so, we have to be careful. We have to make sure we don't stress the zonules too much because inflammation is already present. You might have silicone oil in the posterior chamber. The zonules are already weak. So as much as possible, you make multiple quadrants and then remove each quadrant one by one, which would make the job much more easier. Silicone oil is often present in these eyes, and the problem with silicone oil is that it's actually pushing the iris lens diaphragm anteriorly, and the zonules are weak. If you want to shallow the AC, if you want to deepen the AC, you kind of raise the bottle height, and that works against you because the fluid again seeps back behind the zonules, and you have more shallowing of the AC. So that has to be watched out for. Another point regarding silicone oil filled eyes is that biometry may be difficult. Optical biometry may not be possible if the cataract is dense, so you'll have to resort to the good old ultrasound biometry, where the method I prefer would be to shift the velocity of sound from 1500 to 900 meters per second. That would compensate for the silicone oil. In extreme cases, yes, we've spoken about this as well, where you can go for a two-step procedure instead of a single-step procedure. So to conclude, have a high degree of suspicion in any case where you cannot see the fundus. Be prepared. Counsel very well. The patient would definitely require more than one procedure. Slow down all the parameters of your surgery. You might be an expert surgeon, but it doesn't hurt to actually go very, very slow. And most importantly, be friends with your retina colleague. Thank you.
Thank you. Thank you, Dr. Madan. I would agree 100% with the last sentence because my confidence in cataract surgery actually became better because I have my brother who's there to back up, because that's when we go in for the harder cataracts, knowing that the maximum complication is it can drop and you guys are there. So thank you so much. So as we come to the end of the instruction course, thank you. So I had an amazing team. So all of you don't think that I selected only sports people in my team. So it was wonderful, and looking forward to a great 2 more days in AIOS. Thank you.